Emergency Medical Minute presents Mental Health Monthly. Substance-induced psychosis, the agitated geriatric patient, manic episodes. Paramedics, nurses, mid-level providers, and physicians in the ED all regularly have to manage patients with psychiatric conditions, often with limited training and resources. In this series, psychiatric experts keep it real, raw, and relevant about what you need to know to successfully care for these patients in an emergency setting.
Hello, and welcome to Emergency Medical Minute Mental Health Monthly. This is Travis Barlock, and I'm again accompanied by my friend and colleague, Dr. Andrew White. Dr. White, thank you for joining me. Welcome back to the podcast.
Yeah, thanks, Travis. Good to be here.
So, last time we met, we talked about psychosis and the inpatient and the ED management of psychosis. Today, we're going to be talking about mania.
Ooh, I love it. It's like one of the sexy things in mental health.
So with that, I think we can just maybe get right into it and talk a little bit about just what it is exactly and what we do for it when we see it in the ER, and then maybe what things look like on the inpatient side.
Yeah, sounds good. So, mania is one of those things that if folks listen to the last episode and are wondering about how to approach a patient that could be seen as difficult, I would say falls under the umbrella of a potentially difficult patient. It's, in short, a mental health emergency. So mania traditionally is seen as a distinct mood episode where individuals have elevated and expansive mood, in addition to extremely intense and almost palpable amounts of energy, enthusiasm, and at times irritability. So, for anyone who's worked in an emergency setting, you've probably seen mania, and if you have, you likely remember it based on the severity of how it presents, and really excited to talk about it today. I think the best place to start when we talk about mania to give folks an understanding of what it might look like could be with some of the pathognomonic symptoms or the things that we see across the board in an individual who's suffering a manic episode. And those things can be characterized a number of different ways. I use the good old acronym from med school of D is for distractibility, I for impulsivity in high-risk behaviors, G for grandiosity, F for flight of ideas, A for agitation and increased activity, S is for sleep decrease, and T is for talkativeness. And each of those letters represents one of the core symptoms that the DSM-5 says should be applied to an individual who's showing an elevated mood and increased energy. So you might not be able to say, hey, this person is bipolar or manic depressive right off the bat, but if you see an individual who has in their presentation extreme amounts of distractibility, which is what the D stands for in DIGFAST, you might get suspicious. And so when we talk about distractibility, it could be an individual who even within the conversation of, introductions in the first 30 seconds is unable to carry on a linear, goal-directed conversation because they're getting distracted by your tie or what kind of shoes you have on or something that's in the room, and their mind sort of gets hijacked by that interesting thing and takes them off on a whole train of thought. And when we talk about some of the other aspects, just going through the acronym, the I for impulsivity is something that may be the reason that the person's coming into the emergency room in the first place. So when an individual's in a manic episode, their overall functioning is rather impaired when we think of executive functioning, being able to pause before you act, having an ability to control your desires. And as a result, folks who are manic are usually prone to all sorts of high-risk behaviors, whether it's lots of spending, engaging in sexual activity that they normally wouldn't engage in, having, drag races down the street, even though they're like a 60-year-old woman, or things as remarkable as running down the hallway naked into the emergency room. You can kind of see it all. Accompanied with some of these symptoms is a grandiosity, this elevated mood and this elevated sense of self where individuals really can be anywhere from just feeling so great about themselves on one end of the spectrum, or going even further to delusions of grandeur where you have ideas that people often come in thinking, depending on the individual, hyper-religious ideas like they're the next coming of Christ, or on the other end of the spectrum that they're the devil and that are responsible for all the bad in the world. But effectively, the idea behind the grandiosity and mania is that it is very notable, and it is, again, one of the hallmarks of the illness.
you kind of laid out just almost like a spectrum for this grandiosity from kind of on one end just being like overly confident to the more extreme example of having a delusion of grandeur. That then seems to kind of remind me of our conversation regarding psychosis and delusions. And so I guess if this kind of presentation is manifesting in our encounter, patient who's thinking that they're ordained or something, that they have these grandiose, delusions. Do you find there's any kind of quality to it that's different that makes you think that this is more of a manic picture rather than a psychotic picture? Is it just the overall clinical picture, or is it that the delusions that are seen with psychosis are of a different nature than of this like delusions of grandeur? Is it more specifically just of grandeur exactly?
No, I think that's a great distinction there. Ultimately, I think the best way to maybe draw a line between them would be to first start off saying that mania, if we look at it similarly on the spectrum from, kind of euthymia or baseline mood, and then increased elevation in mood that then leads to a manic episode, one of the downstream endpoints of an untreated manic episode is that individuals can become psychotic. And so there's probably a difficulty in distinguishing based on the content of the psychosis. Like, is this psychosis of schizophrenia origin, or is this something more related to mood, without some of these finer points around the history of what this person's been going through pre-psychosis. So if you're dealing with like Joe Schmo who's coming in and, like you said, thinks he's got powers from God to heal everybody, gonna be really tough to say, well, is this mania with psychosis? Is this psychosis from schizophrenia?
That seems like almost like a trivial difference, but it's probably not, because one seems like a intrinsic fundamental psychotic disorder, as another one is a mood disorder. And so I would imagine then your treatment modalities would be totally different.
Treatments differ, prognosis differs, but as we'll talk about in a little bit in terms of how we might approach it practically, the acute treatments might not differ too much. Okay. Yeah. But yeah, so I mean, it gets to the point where in these manic episodes, folks can be psychotic. The rest of the acronym kind of runs through other aspects that are lived experience of the person. So the F in DIGFAST is for flight of ideas, usually expressed as this racing thoughts. Like, my thoughts are just racing and racing and racing. A little non-specific, right? If you talk to anyone with anxiety or depression, it isn't necessarily true just to mania. But I think one of the aspects that is representative later on in this acronym towards the T is a pronounced talkativeness in addition to these racing thoughts. So an individual with mania is going to be having these racing thoughts, almost tangential in nature, not so much, as we're talking here, going from point A to B to C. They'll just start talking about the weather, and then, I was driving my car here, and my car's a Mitsubishi, and Mitsubishis are made here, and you go on and on down this almost illogical route. And the talkativeness nature is, I think the best way to describe it is it's uninterruptible. Like, if you're working with someone who's manic, good luck getting a word in. Sometimes the talkativeness will span into some of the more intriguing things in psychiatry that we have, which include word salad or clanging. Word salad is basically just words thrown together. Clanging is where words are kind of almost spoken in a like rhymey, rappy sort of way, where the actual tone and the sound of the word connects with the next one in a way that's kind of playful, and at times there's puns mixed in. And if you're working with a pleasantly manic person, it can be like a pleasurable experience to have a conversation with them. But one of the aspects of mania, as you kind of alluded to with the mood nature of it, is that there is sometimes elevated, grandiose mood, and there can be some pretty irritable and, if not depressing, mood in a mixed state mania, where individuals are suffering both from these elevated moods and some of the symptoms we're talking about, as well as aspects of.
That's very helpful. So we've gone through the bulk of the mnemonic. We've done distractibility, impulsivity, grandiosity. That's dig. And then fast, we kind of jumped from F to T with the flight of ideas and then the talkativeness. And then I guess, so what's the A and the S in between there?
Yeah, so the A and the S are things that you'd probably gather from collateral informants or potentially from the patient. But the A is an increase in psychomotor activity, agitation, pacing around. And, from a history standpoint, you'll kind of see that folks brewing up to an emergency presentation have been starting all sorts of projects, renovating housework, and doing so in a pretty unsuccessful manner, almost like starting 5 or 6 projects that they have no previous knowledge of doing. But because of that grandiosity, that elevated mood, like they can do it. Like they'll fix the roof, they'll put up a fence in the back.
Through the startup, I mean, it really sounds super dangerous and risky if you have a patient who is just unstoppably confident and is actually like risking their life savings, other people's, assets. Like you can really see how it really would be tremendously, disruptive to someone's life.
Unlike many things that folks will present to care for a while, this feels great, right? There's something nice about feeling on top of the world. There's something reinforcing about social interactions that sort of energize you. And I think that carries folks through a lot of these activities that begin to occupy their time. Exacerbating this is that last part of the acronym, the S, which kind of stands for sleep changes. It in a nutshell describes, I think, one of the aspects of this increased energy is it's not just, well, this person has all this energy and, they go to bed and they wake up the next day, they've got tons of energy. Typical manic episode almost starts with some noticeable insomnia, sleep issues, not getting to bed as easily, staying up a little later, and can evolve into almost pure sleeplessness for days. And so I've worked with numbers of people who have gone through 3, 4, 5 days without sleep. And I think the big crux of this, if you're kind of working through, is this insomnia related to mania, is this insomnia related to something else, is how the person feels the next day. Because in a manic episode, you feel fantastic, right? People say they wake up and they got 30 minutes of sleep and they are just rolling. They feel great and they're ready to carry on with all these random things that their brain is kind of showing them is possible with the world. Whereas, insomnia, due to the majority of other causes that we know of, are pretty unbearable for few, if not many days. People are tired and exhausted and worn.
So it might even be just like a feature that is unique to mania itself is just the almost like how it doesn't impair them in terms of how they feel afterward. They're so elated in this state that being sleep deprived, just you still feel great.
Yeah, I mean, it does have its limits. One of the aspects that aren't really included in the new diagnostic criteria, but is notable when you're interviewing folks is they're not sleeping, and they're working on random stuff for 20 something hours a day. They're usually not eating, so you can have individuals who come into the ER and they're ketotic just from not eating for the last 3-4 days, because why eat when you're gonna save the world?
Sure.
And so it does tend to burn out one way or the other, kind of as you mentioned, working into the reality of how these folks might present to us. I think usually there's an aspect of sort of this terminal event that leads to folks seeking care, selling their house and moving the family out to the middle of nowhere, and then a spouse or significant other sort of bringing that to attention, like this is off, like we need to do something. Individuals will often run into issues with the law, whether it's committing a crime, or some folks will have paranoia and aspects of psychosis that develops that's not necessarily in the grandiose realm, but more in the auditory hallucinations, negative, you need to kill yourself. And so we'll also see folks coming in and kind of the throes of suicidal ideation.
Interesting. There's again some of that overlap with psychosis, and we can see how there's this blurry kind of space between them. But again, important to differentiate: is it primary psychotic disorder versus is it a primary mood disorder? Interesting. So, and then I guess we've listed out all these features of mania. Now, do you know, is it any certain combination of them that would kind of put you in that category to confidently tell you this person is? I mean, it seems like there's just a kind of a gestalt and recognition overall, but do you think, I mean, I'm sure the DSM has some cutoff
Yeah, and they're cut off. So, criteria A of the DSM says you have to have this elevated mood, you have to have the increased energy. The mood is irritable. It kind of changes the number of symptoms that you would look for that we discussed. But if you have the elevated mood and you have the elevated energy and you have 3 of those symptoms that we talked about, you would be in a manic episode if the duration of that episode has reached 7 days. So there's a little asterisk next to that, though, because, you or I seeing these folks tend to be folks coming into the emergency room or into the inpatient setting. And for those individuals, we consider, all those symptoms. Are they present? Yes. Are they affecting someone's life? Yes. And if you get hospitalized, we kind of say, well, screw how many days it's been. This is severe enough. This is a manic episode. If someone is in an irritable mood and has increased energy, we look for 4 of those symptoms opposed to 3. But again, it's hard to put too much stock in an incomplete history. And I mention that because if you're interviewing someone who's manic, and some of the data that I was looking at suggests that even having a logical conversation only happens in about like 30 to 40% of people who present manic to an emergency.
These conversations are very challenging. I'd actually even ask your thoughts on how best to conduct these interviews, because I can recall conversations with patients who are having manic episodes and getting into philosophical circles and circular reasoning. And then again, whatever kind of pressured speech they have is totally impairing any further history gathering on my end. And so I guess, do you have a recommendation of like how to go about navigating an interview with one of these patients? Because at the same time, like we still need to know, what do you take any medications? Do you have any other medical problems? Like what happened, So like how do you recommend we go about that?
Yeah, so it's definitely more of the art than skill. I think the biggest aspect for any provider potentially interacting with someone who's manic, or even say similarly if you're anywhere in the healthcare setting and you're worried that someone's in noticeable distress, would be to be extremely clear, short, and direct in what you're asking. If individuals, as you kind of mentioned, right, can do in these situations, kind of get off on a random tangent and try to take the conversation a certain way, in those moments, I treat that as data gathering, right? You listen, give them a couple minutes, no harm, if there's no harm. And I think that sort of is a perfect moment to pause and mention that in all of these situations, particularly with an individual who's maybe been manic now for a few days, on weeks, it could very well become a safety concern. And so if at any point in the interaction you feel as though this person is feeling cornered, getting even more agitated, don't even worry about what they're saying. Leave the room, get back up, call security, and do so in a manner that's pretty much in line with, as we talked about, with folks that are undergoing psychosis, sort of patient-centered, but also safety-centered for the entire staff that's there. I think out of individuals who are prone to potentially turn the corner towards violence and assaulting staff, folks in manic episodes tend to be at the top of my list to kind of watch out for. Okay. In practical terms and epidemiologically speaking, they're not necessarily at an increased risk of having violent outbursts, but something about the mixture of, severe mental illness and locked doors and people in white coats can bring out a lot of paranoia and some of those mixed state features of, potentially psychotic things, hearing voices. And so if you have those points of knowledge that you need, right, what happened, what brought you in, ask them directly, try to get an answer. But if you've asked 4 or 5 things and you're getting this diatribe about some manifesto that's going to solve the world's issues, yeah, again, that's pretty solid data that this person's brain has got flight of ideas, they're tangential. And then I think one of the big distinctions as you're trying to make that call between is this mood-based or is this psychosis-based is what you're going to observe in the person. A manic individual, at least based on the ones that I've seen up to this point in my career, is not going to sit still and have a conversation with you. It's almost counter what their entire being is doing in that moment. And so if the person is spewing some psychotic, interesting things, but chill on the bed, legs crossed, just hanging out, could start thinking about some of the stuff we talked about in our psychosis episode, whereas an individual with mania is going to be pacing, moving around, moving their hands, moving their body, and a notable rest.
Kind of getting back to that A and like psychomotor agitation. It's just kind of everything's revved up.
And so it might not be a patient that you pull up a chair and sit down and talk with, just out of your safety and out of the practicality of a conversation, and try to match their posture and just understand that, ultimately, as we kind of talk about the workup of this and the treatment, some of that history that we might gather is probably not as important as treating this as immediately as possible.
That's very helpful. I think then that's a good segue into the initial workup in the ER, and then maybe talk about, I guess, what happens on the inpatient side. So you kind of already alluded to one big branch point that I'm very familiar with, and that's just the patient who is agitated. And to me, that there's just that clear-cut line between a patient who is, agitated and cooperative. And I guess when we're dealing with the agitated patient, it's are we dangerous agitated or just kind of disruptive? And for me, it's when you're agitated, dangerous to either staff or to themselves. They need a head CT and we need to rule out, an intracranial hemorrhage or something. Then to me, they need probably intramuscular ketamine immediately, 3 mg per kg, and have airway equipment at the bedside for that. Very possibly might need to be intubated. Definitely will be on constant cardiac respiratory monitoring with nursing and probably the doc at the bedside for the entirety of that encounter. And then there's the disruptive agitated patient who my go-to medication, and I think we possibly spoke about this in the psychosis episode as well, is I usually go with droperidol and plus or minus adding Versed for the speed of onset rather than anything else. I feel like that's what we really care about in the ER is speed. So agitated dangerous is one thing, agitated disruptive another. Does that gel with your approach to a patient who is acutely agitated?
I think the image of like having someone there to intubate is just like so wonderful. We don't get that in our our side of things. But yeah, y'all can really knock some folks out if it's in their best interest. But the same dichotomy plays out when you send someone to the psych emergency side. How much of a legitimate concern is this person's safety right now? Do we need to go intramuscular? And that's about as far as we'll go before we send folks over to your end on the emergency side. Or are they, at least willing to discuss the idea of taking meds? Usually what we'll use in a more, let's say acute agitation needs to be medicated right now, to throw out some other options. We'll do some Ativan, a couple milligrams of that, maybe use some Haldol depending on what sort of exposure this person has had to antipsychotics in the past, or, depending on where you are, there's some other intramuscular antipsychotics that individuals will use. I think the benefit to some of those treatments with antipsychotics is if someone's been, say, diagnosed bipolar previously, and this is a second or third manic episode, you might have an idea of something they've responded to in the past, understanding that medication compliance, or non-compliance for that matter, is one of the main factors that's been associated with manic episode recurrence in someone who's had it before. But yeah, no, I agree. I think it's the same fork in the road that we often stand as we're taking a deep breath and about to enter a room of someone who's pretty agitated.
If you have the benefit of good history and information on what they've responded to, then that might change some of your choices in medication selection. I think that's a great point. Now, I guess when you have the cooperative patient, and I guess once the acute agitation in the uncooperative agitated patient has been addressed, then I still always think that there's still the medical screening that has to happen first, followed then by our psychiatric workup. And I think kind of similarly to a patient with acute psychosis, there's basic lab work, CBC, BMP, and LFTs that we're obtaining. I think it's definitely smart to get an EKG, check to see is there any QRS widening, QT prolongation, evidence of sodium channel blockade. Urine tox screen, I feel like is going to be part of any one of these workups, see what kind of confounding medications could be on board. And then Can never forget to get a pregnancy test in our women of reproductive age. We know, CT imaging of the head is useful if there's localizing neurologic symptoms. We would do that anyway. Thyroid testing is always possible if we're considering that on our differential or their risk for autoimmune disease. And then, taking a good kind of medication history to see what meds are on board.
Definitely. I think one of the red herrings that exists where both of our practices intersect is, the idea of substance-induced mania, right? There's the traditional mood-based mania that we're talking about, but it is imperative to rule out any medications that have been started recently, in addition to some particular drugs that are out there these days, methamphetamine and my mind most vividly, can create something that looks very much like mania, a manic individual. In that regard, I think the only other thing I would throw into the differential is potentially like an agitated delirium. Like if you're seeing a patient on the floor who is sort of out of sorts and got a change in their consciousness, pacing, and that sort of takes a little bit of digging into the history and the pattern, because mania, even if we have an individual that's very agitated, safety risk, we medicate them, it's not going to go away the next day. It's not something we cure. It definitely ends up being a situation that opens the door to long-term treatment, and usually individuals with bipolar disorder earn themselves, rightfully so in many cases, both these acute medications that we're talking about to help with the mania and then some long-term mood stabilizer, usually in combination with an antipsychotic.
Can you see mania come out in patients in withdrawal states?
Yeah, so there is not a lot of connection in the literature, but I would say based on my practice and working in a few different rehabilitation centers, we've had individuals coming off benzos in the past who had a manic reaction, and turns out the more you dug into that person's past, like they had distinct mood episodes prior, which is maybe just a little aside about how bipolar can be a little shifty, and many folks who present in a manic episode maybe have had many unrecognized episodes of hypomania, which is kind of like mania light. It's not affecting your life in the same way, and it lasts for less than 4 days. So understandably, maybe not something you run to your doctor to talk about. And many folks with bipolar disorder spend the majority of their life in depression. And so this mania aspect is something that will be a part of the picture, and ultimately oftentimes can suggest certain treatments there.
Similarly, in that vein, just talking about some of the things that can trigger this, you mentioned amphetamines. What about psychedelic drugs? Would you see mania come about with drugs like LSD or psilocybin or ecstasy? Other than stimulant seems like a natural thing that could kick this off, but what about other drugs?
Yeah, so one of the first drugs, if we're talking more illicit substances that comes to mind, especially practicing here in Colorado, is marijuana. There seems to be individuals who, when they smoke weed, it elevates them and can lead to manic episodes or just prolonged manic feelings that tend to get better when they stop smoking weed. But because of that relationship, it's kind of hard to convince someone who's feeling great that they need to stop smoking the thing that makes them feel great. Psychedelics don't have as much evidence around causing or not causing. I think as they become more mainstream in their practice, we'll probably have some more evidence there. But experientially, I've had individuals who have used psychedelics and less in the mania spectrum, but more in the psychotic spectrum, have had symptoms that persist long past what we would think those drugs are in their system. And then the other drug I would throw out there is more the drugs we use, which is antidepressant medication. Many times folks who didn't really know they were bipolar get started on the antidepressant in good faith and will have a switch into mania. If that person continues to have manic symptoms after stopping the medication and letting the med wash out from their system, they've been officially, at that point, diagnosable with bipolar disorder, which I guess to maybe tie up a loose end there, any individual that has a manic episode earns the right to be called bipolar.
So just one episode, you're diagnosed. Another thing that we often encounter just in the ER is just the decision to place patients on a mental health hold on an M1 here. And to me, I would, we talked about this again in our last episode about the criteria for that being at harm to themselves, others, and then imminently or gravely disabled. And so to me, again, the question of are you suicidal, homicidal is like less important here, and it's more just the recognition that these patients are clearly at grave disability. When you're talking about selling your home to create your new startup that you just came up with the idea yesterday or whatever, that seems like a person whose life is very much in jeopardy because of their mental state. And so I feel like very clear to me it would make a lot of sense to place these patients on an M1 hold.
Yeah, I think this is one situation, depending on the details and depending on, maybe this person's electronic medical record, and if you feel that there's good reason to believe this is a legitimate manic episode, I think it's one of the reasons that we have grave disability as a way to exercise this authority of evaluating and treating people who might not desire that, right? I think one of the things that comes to my mind when I look at mania is this notion of endosygnosia, which is like not being able to recognize what's going on in your own brain and in your own existence. And it's pretty characteristic of many mental illnesses. But folks who are manic, the last thing that they will admit to you is that they are sick and something is going wrong. And that's, it kind of flirts with that psychosis-y world where, their reality is different from the reality we're all kind of living in. But, many folks might not be suicidal. They might not be homicidal. But that train has left the station around their ability to care for themselves. And I'll be honest, there have been times earlier on in my career when I was doing more emergency work where we'd say, oh, this person looks kind of like hypomanic. Let's just give them a little bit of Seroquel, get some sleep tonight, and we'll see if we can get them set up with some close outpatient follow-up. And 3 days later, they're back with police at their sides bringing them in because they're running down the street, wreaking havoc. And so, I guess I share that to say it's a situation that for me, at least personally, I'm a more I'd rather be safe than sorry. I try to support people's autonomy, but when I'm working with an individual like this, I share with them, I'd rather you spend a couple days in the hospital, we see where this goes, opposed to you go back to where this started and hope that something's going to miraculously change.
Yeah, totally. Could you share, I guess, a little bit about what does happen on the inpatient side? I think we've talked a lot about just the initial kind of recognition of what a patient in mania, looks like. What we do in the ER as far as stabilizing someone who's agitated or not, and then what kind of initial workup do we get to kind of set the table going forward, and then ultimately they end up leaving and hopefully getting placed in some inpatient psychiatric facility. What do you guys do when that happens?
Yeah, we batten down the hatches. Usually if there is kind of handoff that someone is acutely manic and coming upstairs, that the first aspect that we try to take is more of an environmental approach, right? Which I'd recommend to anyone in the emergency room setting too. But how do we make sure that the lights are as calm as possible? There's not 3 manic people running around at the same time. Just practically speaking, let's get this person a room that's maybe a solo room if we can, and we start to treat right away. And so individuals with a manic episode, if they've been medicated in the emergency room or not, will usually get treatment with both an antipsychotic, which is usually best for some of the short-term agitation and the acute agitation that we see, and that can span. Usually folks will try probably olanzapine, risperidone for some of the atypicals. Those have the advantage in certain formulations of being orally disintegrating. So folks, if are prone to maybe spit out their meds or cheek them, you can give them these ODTs and they work pretty well. And you can get folks pretty calm with that combination of an antipsychotic and plus or minus a benzodiazepine or something to help them get through the night. In those moments, if someone can consent to treatment and we can talk about other options, we'll usually open the door to mood stabilizers like lithium, Depakote. Those are our main go-tos in the inpatient settings because, for example, with Depakote, you can load someone with a couple grams if you need to. And lithium, as long as someone's kidneys are okay, is a pretty safe choice that's got some of the best evidence for both depression and mania. So yeah, the first few days are kind of tucking people in, trying to get them as much rest and calm and peace as possible, and then setting them up for the long-term treatment of bipolar disorder, which again usually involves at least a mood stabilizer, and then in some people a mood stabilizer and antipsychotic. The long-term treatment options are vast. Most people respond really well to psychotherapy, and then group therapy and family therapy is usually important for individuals, understanding that bipolar disorder usually peaks in the early 20s. So you're looking at people who are like at a very interesting stage of their life, just getting out of high school, starting college, maybe starting a new job, starting families, and then they get this diagnosis of a chronic mental illness that is pretty serious. It's about as serious as they come. And so we try to work with families to set them up with organizations like NAMI, the National Alliance of Mental Illness. They've got some good psychoeducational groups. And then long term, making sure that someone has an outpatient psychiatrist they trust. And then it's just really a game of trying to prevent the next episode. Ultimately speaking, about 90% of people who have a manic episode will have another one in their lives. And with each manic episode, there's neurodegenerative changes, people are at risk for dementia, and their return to baseline functioning is usually compromised.
I see. And the medications that they're commonly on outpatient, are they those mood stabilizers that you just mentioned, the lithium, the Depakote, or are they on antidepressants and antipsychotics as well?
Yeah, so I think the other mood stabilizers that might get started in the outpatient setting could include things like Lamictal. And then we also have seen with some of our atypical antipsychotics that they serve as a mood stabilizer in monotherapy. So if we look at Zyprexa, Seroquel, Abilify, all of those have really good evidence long term, as long as you are able to manage some of the metabolic side effects that could accompany. I think a few of the difficulties around conundrum is, okay, we're talking about acute mania treatment, getting someone stable and back to their baseline. And the vast majority of individuals after a manic episode go into depression, right? About 60% or so. And so, you wonder, as you kind of said, what other things can we do? Antidepressants are not particularly first line given the potential to switch someone back into mania, but we do it if individuals have depression that warrants it. The first line, though, is usually an atypical antipsychotic. So a few of them are approved for treatment of depression in a bipolar individual. And those are like Seroquel. You can also have Latuda, which is lorazepam. Olanzapine and fluoxetine have been added together into a pill to get approved and be sold all over the world. And yeah, I think the big dilemma is that, we treat the mania and then we're stuck with an individual who is both at huge risk for depression throughout the rest of their life, and there's not great treatments for it. And so we try to supplement that with diet and exercise and lifestyle modification. And most people are able to maintain a fairly decent balance between their baseline mood, avoiding mania, and if they start to get hypomanic, usually aggressively treating that with increasing antipsychotics or benzos.
I think I've heard at some point that there are some theories that some of these mental illnesses may start with sleep disruption. And it's interesting how they often are accompanied by sleep disturbances. And so just mentioned how, diet and exercise are going to be key into this. I really wonder how important the role is of regularity with sleep and sleep quality and things like that. And it just seems like such a natural connection between our mechanism for brain recovery and for preventing these manic episodes. Do you know if there's any, it seems intuitive, but I just don't know if there's any actual data on it.
Wholeheartedly support that notion. Data-wise, I don't have any facts on the top of my head, but I would say some of the earliest warning signs that someone is on the up towards this up and up of mania is kind of fractured sleep, going to bed a little later, waking up a little earlier, and almost, in interviews with them and talking to folks, just, having a noticeable change around even their desire for sleep. It's like, oh yeah, go to sleep, but like, you have someone who's kind of got insomnia at baseline, and then you talk to them, and it's like, oh yeah, it's not an issue anymore. Well, how much are you sleeping? Oh, like 5 hours. And so, like, suspicions raise. I think the practice that I've developed is to treat that aggressively. Like if your sleep's starting to get out of whack, we're definitely not going to go down on your meds or see each other less frequently. Like this is something we need to watch. And I also have recommended to many folks, there are just certain occupations, certain aspects of their dream job where they're like, oh, I want to go and like be a DJ in the club all night. And I'm like, okay, you're playing with fire. Like you can, but there are many cases in my head that support what you're saying. Like this sleep is it's the bedrock, right? Like it's the cornerstone.
That is super insightful. Well, Andrew, I think we've talked about a lot of aspects of this. And I got to say, I think that this was super helpful for me. And hopefully our listeners also took something from this. Talked about the initial recognition of mania, how to try to conduct an interview with someone who is in a manic state, the initial discrepancy or delineation rather between an agitated and cooperative patient, some of the initial labs that we get and workup that we start, followed by what happens on the inpatient side and some of the things that we can look for that might cue in, like that might clue us into a patient that's at risk for having another manic outburst. Dr. Andrew White, is there anything else you'd like to add?
No, I think that sums it up. And I think if you treat them like people, you'll at least hopefully not get punched. That's the goal, right? Like, that's all I got. It's the best.
Yeah, I appreciate that advice wholeheartedly. Well, Dr. Andrew White, thank you so much for coming back on the podcast.
Anytime.